So good morning and welcome to the 2021 El Camino Heart Forum. Thank you all for taking time out of your Saturday to join us today. This is now the 11th time that we have done this event, and obviously it's the first time that it's a virtual event. So please bear with us through this adventure. It's going to be interesting and hopefully exciting. This morning we're going to be treated now to a series of presentations which reflect topics that for the last few years have clearly sparked quite a bit of interest in our community. The presentations then will provide what really excites me is a launching pad for what I hope will be some very animated and informative discussions. We're going to have a discussion at the end of each presentation, and at the very end of the whole gathering, we're going to have a panel discussion where we bring everybody back. So now everybody, take out your pencils, take out your pads, because there's going to be a test at the end of each presentation. No, just kidding. There's not going to be a test, but what there is going to be, and I really hope everybody here is actively engaged in this, is there is a dynamic chat room. And there's an opportunity, I think it's at the bottom of your screen where the chat is, for you to ask questions. And please be very animated and active with that. Now we are going to then try to filter those questions and get to them with each presentation. And I want to point out that if your question doesn't get answered, there is going to be then an opportunity and follow-on to deal with those questions. So now before we launch into our presentations, I have the great pleasure of introducing my good friend and my partner in cardiovascular health and wellness oversight, the Executive Director of the Norma Melchor Heart and Vascular Institute, Ms. Amy Marr.
Hello there, everyone. Welcome to this year's annual Heart Forum 2021. I'm Amy Marr, the Executive Director of the Heart and Vascular Institute, and I'm pleased to have you here today. You can see here our agenda for the day, and I wanted to let you know that today it's all about you. We chose the topics you see here today by serving you and you letting us know what you want to hear about the most. In terms of the flow of the event today, Dr. St. Gore will give you an introduction to each of the speakers, and at the end of their brief presentations, you will have ample opportunity to ask your burning questions. At the end of the individual presentations, this is your opportunity to ask questions by our team of experts. Before we continue on, I want to say a special thank you today to Donna Garcia, our Operations Coordinator at the Heart and Vascular Institute, to Holly Trollman, our Marketing Manager, and to Brian Richards, the Manager of our Audiovisual Program. I also want to invite you, after today's event, to take a brief survey that we will be sending you a link for to help us to understand what was great about today's process, what we might be able to do better next time, and perhaps what you might want to hear from us at our next event. So who is the Heart and Vascular Institute? We are a team of phenomenal physicians, surgeons, cardiologists, interventional cardiologists, highly specialized nurses and technicians, advanced practice nurses, clinical educators, data experts, clinical leaders, and administrators, all working together to ensure that our community is receiving the best possible cardiovascular care available to them. We also work in close collaboration with these partners, the Cardiopulmonary Rehab Center, the Taft Center for Clinical Research, our Women Heart partners in the community, the South Asian Heart Center, Fogarty Innovation, and the Chinese Health Initiative. We all work together to ensure that we are adequately assessing and meeting your own unique needs. So I wanted to share with you some of our top accomplishments over the course of the last year. It's been a tough year for all of us, but we've managed to accomplish a great deal. First and foremost, we were the first hospital and health system in the state of California to achieve the American College of Cardiology's Valve Center of Excellence designation. This award recognizes that we have superb clinical care pathways, transparency in outcomes reporting, and our quality review practices and the processes we use to follow our patients long term. We have also, for several years running, been rated outstanding for myocardial infarction or heart attack care. We have national accreditation for our Cardiopulmonary Rehab Center, for several years running excellence in rating for our echocardiography program. And our surgical program for aortic valve replacement and mitral valve repair and replacement is 3 stars, or the best in the nation. That puts us at top 2% of all performing hospitals for these procedures. We've also most recently been awarded from the American College of Cardiology 4 stars ratings for myocardial infarction care, as well as percutaneous coronary intervention. So what does this mean for you? It means that you can be assured that when you receive care at El Camino Health, you are receiving the right treatment at the right time to meet your own specific needs. It means that across our entire experience with you here at El Camino, and even once you leave this hospital, you can be confident that we have your health, your treatment, and your recovery as our first priority. So what's next for the Heart and Vascular Institute? So knowing that we already provide top-notch care, here's what's next. This time last year, we moved into the beautiful Sobrato Pavilion, and we opened several cardiac specialty clinics, our Women's Heart Center, the Oncology Center, and we co-located cardiovascular diagnostics within the building as well. And we are excited to announce that we will also be moving the Cardiopulmonary Rehab Center within the Sobrato Pavilion next fall. We will also be expanding and upgrading equipment in our catheter lab so that we can ensure you that we continue to have all of the state-of-the-art therapies available to you that you've come to expect. We will begin a vascular screening program in Sobrato Pavilion as well, and expanding our wound care services. We have great plans to consolidate CV services as much as possible into one location, making cardiac care for our community as convenient and comprehensive as possible. So before I say goodbye, I wanted to make sure that I mentioned to you Dr. Frederick St. Gore. Dr. St. Gore is the medical director of the Heart and Vascular Institute and my partner in leadership. He is a thought leader in cardiovascular care nationally and internationally, and is the owner of the company that invented the MitraClip, which you'll hear about very soon from Dr. Ramahan. So thank you for your time today, and please enjoy our presentations.
Wow. Thank you, Amy. That was a great tee up. And Amy, let me thank you. You are just a wonderful partner in all of this endeavor. And I think we both can agree that El Camino, and certainly the Heart and Vascular Institute, is just it's a really phenomenal place to work. I think, as you can probably all tell out there in the audience, Amy is both the inspiration and, truth be told, also the disciplinarian who keeps all of us at HVI moving in the right direction. And we certainly love her for it. So I want to tell you that I am truly honored to help direct the Norma Melchor Heart and Vascular Institute. And suffice it to say, there are several perks that are included in that position. First and foremost is the opportunity to work with an amazing staff of individuals, an absolutely amazing staff, which includes now 20 advanced nurses, data managers, and clinical staff who directly track and manage all of the day-to-day goings-on in cardiovascular care at El Camino Health. This really is an impressive team. Amy showed you a picture of them. It's really quite a dramatic group. And they really help to guarantee that only the highest quality of care is delivered at El Camino Health. I also get the great privilege to work with 10 physician medical directors of our various cardiology service lines. These docs truly are a group of rock stars, and I'm quite excited that we're going to be able to hear from a good number of them today in our forum. So the other fun perk that I have enjoyed now for a number of years is the opportunity to MC this annual Heart Forum. And this is the point in the program where I usually stand up and I look out at the audience and I ask, well, how many of you were here last year? And how many of you have been here for 2 years, 3 years, 4 years? And people are raising their hands and giggling and laughing, and it's always very entertaining and interactive. And in fact, 2 years ago, when I did this at what was in the 10th anniversary, there are actually a few attendees who had been to all 10 heart forums. Now, I'm not sure whether they are slow learners or that's just that they really enjoy the event. And honestly, I'm assuming the latter. And I also hope that those people are still here with us again today. So obviously, I can't do a call out today and have that interaction in this virtual format. And for that, I am a little disappointed. But that said, today we are going to work hard to make this as lively and interactive today as possible. So 1 year ago on Friday, February 28th, 2020, was a very, very memorable day personally for me. So all the HVI staff had been working really their backsides off, getting ready for what would have been our 11th consecutive forum. And we were going to do it in the new Sobrato building. We had a space which could accommodate 300 people, which was significantly larger than we had been able to do in the previous forums. There was a lot of excitement. We had blown up the balloons. All the HVI cupcakes were ordered. And then Friday morning, literally the day before the event, I was awoken by a ping from Amy Marr informing me that the event was canceled. And I was like, what the heck? I mean, seriously, you canceled? Got to be kidding me. All the work, all the effort that had gone into it, I was blown away. The issue was that the day before, the very first COVID patient in Northern California had been admitted to El Camino Hospital. And the hospital then was immediately put on COVID lockdown. It really was an unforgettable moment. It was a defined moment in time that I will always remember. And obviously all of us at HVI were devastated given all the hard work that already had been put into preparing for that forum. So suffice it to say, since that day, nothing has been the same and nothing has been normal. It's been a very sobering, and I think we can all say a challenging year, but through it all, El Camino and its phenomenal staff have been an amazing pillar of incredible care and caring in our community. And so we've managed over 1,400 COVID patients, of whom 780 were treated as inpatients and were hospitalized. Taking care of all of these patients was an absolutely Herculean effort for all of the over 3,500 El Camino Health employees. But honestly, and I say this sincerely, I feel that we have definitely turned the corner and there is a brightening light now at the end of the tunnel. I'm proud to share that we have vaccinated, that El Camino Health has vaccinated over 20,000 community members, and we are actively engaged in ramping up this process. So as we get access to increasing quantities of the various vaccines, we will do our very best to deliver it to the whole community as quickly and as efficiently as possible. It's been a tough year for all of us, and one which hopefully will soon be in the rearview mirror. And that is the reason why it's only appropriate today that we move beyond COVID and honestly redirect and re-energize our focus on health and wellness. And that is exactly why we listened carefully to the feedback from the last few heart forums and have tailored a program which focuses on the energy and the optimism of wellness. As Amy already showed on her slide, we have an excellent lineup of speakers, rock stars. Jane Lombard, Dr. Lombard, director of the Women's Health Program, will share with us issues on women's heart health. Dr. Deepu Nair, who directs the Cardiology Echo Service Line, and Dr. Chad Ramahan, who's the director of the Cardiac Cath Lab, will bring us up to speed on the latest advancements in diagnostic and interventional care. And we will then finish up by hearing from Dr. Neil Scott, who directs the Cardiopulmonary Wellness Center, and Dr. Kate Collings, who directs the Lifestyle Medicine Program. And they will focus on what we can do to maintain and to optimize our overall cardiac fitness and wellness. And then to remind you, after each talk, we are going to have a question and answer period. So please send in some good questions. I've also been informed that if your question doesn't get addressed and you want to connect to a specific doctor, there is a Connect with El Camino Health button at the bottom of your screen. And if you don't see that, I think you have to just expand it a little bit and it shows up. So finally, let me finish with one or two very important housekeeping items. First, the bathroom is wherever you can find it in your house, and hopefully refreshments are in your refrigerator. So let's get started. We'll kick off the program now with a talk by Dr. Jane Lombard. Jane and I did our medical training together at the same time. It's a few years ago, actually more than a few years ago, at the Stanford system. And truth be told, Jane was in a program where she spent a good number of her rotations at Santa Clara Valley Medical Center. And I was totally envious of her because as compared to the Stanford Ivory Tower where I spent a lot of time, the Valley Medical Center is where you really learn to manage real medical problems. So Jane had an incredible experience for that. She then went on to have a very distinguished cardiology career at Camino Medical, and then recently has taken on the leadership and the challenge of establishing a women's heart health program here at El Camino Health. And she's now going to provide us an overview of this. And thank you, Jane, for doing this.
Good morning, and thank you for joining us at the 2021 El Camino Health Heart Forum. My name is Jane Lombard, and I'm the Medical Director for the Women's Heart Center. Today, I'm going to talk to you about women and heart disease and what we do at the Women's Heart Center. We take care of women who already have cardiovascular disease and also women who are at high risk for having cardiovascular disease. We also take care of women who have conditions that are primarily affected in women, and that of course includes pregnancy. So we have a budding cardio-obstetrics program. Finally, I will share with you what we do in cardio-oncology, which is a program that takes care of women who suffer from side effects of cancer treatment, side effects that affect the heart. So, heart disease in women. What's the difference between men and women? This graph depicts the historical prevalence of heart disease in men and women over the last 60 years. As you see, in the 1980s and 1990s, the death rate for women exceeds the death rate in men when it comes to cardiovascular disease. In the late 80s, statins were introduced, and you see the blue line, which represents the men, the death rate starts going down. However, the red line remains unchanged and actually still continues to go up. So women are underdiagnosed and undertreated when it comes to heart disease. In the early 1990s, the WHI, or the Women's Health Initiative, demonstrated that estrogens didn't really help prevent heart disease. In the late 1990s, generalized hormone replacement, or HRT, was stopped. And in the early 2000s, a public education campaign, the Red Dress campaign, was introduced by the government and the American Heart Association. And with these three interventions, you see the red line start coming down and actually crosses the blue line for a very short period of time in the early, about 8 or 9 years ago. But as you see, both lines are starting to go up, and that's not good. So what's the difference between men and women? Well, women tend to have more atypical symptoms. Instead of just chest pain, we sometimes have back pain or arm pain. There's a lot of shortness of breath, and I see women with nausea, dizziness, and a lot of sweating. These unusual symptoms tend to delay diagnosis, leading to longer times to treatment. And we say door to balloon, that means longer times to get angioplasty or stenting. This causes worse outcomes and, of course, longer hospital stays and higher death rates. Women also are undertreated when it comes to risk factors such as high cholesterol, high blood pressure, and diabetes. Women have more side effects from medications, particularly blood pressure medications. And all these causes increased cardiac mortality, particularly in young women. And at the same time, the American public is becoming less healthy more obese, and more sedentary. With all these changes, there is increasing inequities in healthcare. Now I'm going to share with you some conditions that primarily affect women. These conditions demonstrate how physiology in women can be so different when compared to men. The first is spontaneous coronary artery dissection, or Scad. 90 to 95% of these patients are women. Usually they're young women. And 17% of Scad patients suffer Scad in the peripartum period, usually right after delivery. And this cohort is extremely young, the average age being 35. And the rest of these patients, I would think, are still pretty young, with an average age of 48. Scad may be associated with fibromuscular dysplasia, which is kind of like scarring inside the arteries. And neither one of these entities are well understood, so we need more research. Another condition that we see that primarily involves women is Takotsubo's. Takotsubo's is also known as broken heart syndrome. Most of these patients are women, usually elderly women. And this condition is precipitated by intense emotional stress or severe pain. It is related to the sudden surge in adrenaline. The adrenaline causes the arteries on the heart to constrict and limiting blood flow. And this causes the heart not to contract. And so in this picture, you see the heart muscle sort of ballooning out, forming like a vase-like structure, or as the Japanese calls it, takotsubo, an octopus pot. Fortunately, most patients recover completely, but again, it is very unusual because most of these patients are elderly women. Another condition is MNOCA. MNOCA is a relatively new term. It stands for myocardial infarction or ischemia with non-obstructive coronary artery disease. When patients have a heart attack, we do angiograms to determine if they need to have an artery open or stenting. And we find that 5 to 6% of all heart attack patients do not have an obstructive lesion or blockage. This is called MNOCA. Most of these patients tend to be younger women. They have fewer traditional risk factors such as hypertension, diabetes, or high cholesterol. This diagnosis is made after all other causes are excluded. Cardiac MRI or PET scans may be helpful. The pathophysiology is attributed to microvascular disease or small vessel disease and endothelial dysfunction. Unfortunately, we have no big randomized studies to tell us what's the best treatment. And also, 25% of these patients have persistent symptoms such as chest pain or angina. Now, you all know these pictures. Well, one picture. This is Whistler's mother, originally titled Study in Black and White. And there's my friend accepting the Getty Challenge, posing as Whistler's mother during the corona pandemic. So we're going to talk about pregnancy and heart disease. There are two key points I want to bring up about pregnancy and heart disease. One is the immediate complications and the cardiovascular causes of death in women around pregnancy. And the second is how pregnancy can be associated with an increased risk, a future increased risk for cardiovascular events for a mother. Now, this slide is from the CDC, and you can see over the last 20 years, there has been an increase in maternal mortality in the United States. Unfortunately, we rank very poorly among rich and developed nations as far as our maternal mortality is concerned. Cardiovascular disease is the leading cause of maternal mortality in the United States, and that is probably due to an increased number of women, mothers with acquired heart disease. We also see an increasing number of women with congenital heart disease who are now older and surviving to reproductive age. So currently, we have 17 maternal deaths per 100,000 live births. 26% of all U.S. pregnancy-related deaths are due to cardiovascular causes. And when you include hypertension, stroke, or other thrombotic causes, this number goes up to over 50%. And this is related to the change in risk profiles of American mothers. We're older, there's more extensive use of IVF. We have older mothers with congenital heart disease, etc. The Cardio-Obstetrics Clinic focuses on early detection, prevention, and management. And another pointer on cardio-obstetrics, African American moms do worse. They have about 38 to 39 deaths per 100,000 live births, almost double the white population. The other very interesting thing is how adverse pregnancy outcomes can affect or be a harbinger of future cardiovascular events. What's an adverse pregnancy outcome? An adverse pregnancy outcome includes preterm birth, stillbirths, IUGR or intrauterine growth retardation, or basically very small babies, multi-gestational pregnancies, so twinning or triplets, etc. All those are associated with almost up to fourfold risk for future cardiovascular events. And 10 to 20% of all pregnancies are associated with an APO. Now, this may be because the placental dysfunction and endothelial dysfunction share a common pathway. The placenta is a very large vascular organ. So currently, the American College of Gynecology and Obstetrics, ACOG, recommend that women with adverse pregnancy outcomes and other cardiovascular risk factors undergo screening within 3 months postpartum. And this is a picture from the CDC trying to make public a educational campaign regarding maternal health. Finally, a few notes on cardio-oncology. So what is cardio-oncology? Cardio-oncology is the diagnosis and treatment of the toxic side effects of cancer therapy on the heart. The therapies could include radiation, chemotherapy, antibody therapies, and more recently, the targeted T-cell therapies. We are seeing more patients with complications as there are more cancer survivors living longer. And of course, there are new drugs invented almost every week. Cardiotoxicity may be manifest as heart failure due to cardiomyopathy or weakness in the heart, arrhythmias, which include ventricular tachycardia and atrial fibrillation, hypertension, heart attacks, blood clots, pericarditis, valvular disease, myocarditis, vascular disease, and cytokine release storm, which is a massive immune response, systemic immune response that is pretty rare but very lethal. All drugs have different side effects, and sometimes these patients on a combination of treatments for their cancer. This ends my talk, so I thank you for your attention. And this is the Sobrato Pavilion, where we're housed on the first floor. And if you have further questions or need an appointment, this is our contact number. Thank you again, and have a great day.
Thanks, Jane. That was great. So I want everyone to now take their pad and their pen because it's the first quiz question. And the first quiz question is a tough one, is what is the Japanese word for octopus? You all got that one? It means you were listening. Thanks. No, sakasubos. And it's interesting as to the shape of the ventricle and how it actually looks like an octopus. So it's really humbling to wrap our heads around the idea of how different the symptoms of women's heart disease are. And this certainly has led to a vast amount of underdiagnosed and undertreated women's heart disease. Jane, as you clearly described, the Scad, the sakasubos, that's the octopus, and Minoka, it's also a significant problem for younger women. So personally, I feel that it's really important that we as male physicians, that male partners and family members be much more tuned into this if we are to be good, sensitive, and effective health and wellness collaborators. So let's bring Jane back on and let's take a few questions from our audience. I can also see there are a lot of hands being raised out there in the chat room, and thanks for that. So great, there's Jane. So this is going to be interesting because, as I say, I've got a whole list of questions here. One that I think is pretty good and pretty generic to start with is, I'm a middle-aged woman when would you recommend I see a cardiologist for the first time?
Well, I think it depends on what kind of risk factors you have and what your family history is. But if there's any question, if your internist can probably handle most of the questions, but if you have greater concerns, certainly give us a call. I mean, it's better to be more careful than ignore something.
That's good. Wise advice. So there are a bunch of questions here about estrogen replacement. And I think the best way to frame those questions is, do you want to make a comment on how women's heart risk factor and profile changes with menopause, and what the status is now of estrogen replacement? I know every few years it kind of swings back and forth.
Wow. So the estrogen replacement issue, I mean, I have 20 minutes for the Q&A. But the estrogen replacement issue could probably take a whole hour. And just to summarize, for a long time, we were giving people estrogens because we thought, wow, women, don't get heart disease until after menopause. So maybe it's the estrogens. And it's good for your bones, et cetera. But then the WHI, the Women's Health Initiative, showed that actually that's not the case. So if you break down, so the Women's Health Initiative, they follow 26,000 women. The average age is 62, which is still pretty young. They followed them for decades. What they saw was that, pardon?
I said, that sounds really young to me and you, I'm sure.
Oh, yeah, totally. It's barely middle age, I would say. So, but the women, what they found was women, they looked at the cohorts of women between 50 and 60, and there was a small benefit as far as reduction in heart disease and actually even cancers until they in that age bracket. So, and then as they got older, that effect became neutralized, and actually in women over the age of, 60, late 60s, they found that the incidence of heart disease and especially breast cancer starts going up. So the current recommendation is not to use estrogens in everybody. I think it's like a lot of things we're learning now. There is no templated treatment. You have to take every patient as an individual, and so it depends. I mean, you have a high risk for osteoporosis, then you might consider doing the estrogen. Same with the calcium and the vitamin D. I think that we also need to know, like, why are the patients recommended estrogen? What are their symptoms, and what are their risks for breast cancer? So it all goes down to, I think, we need to really focus on personalized care. Making a treatment plan in conjunction with the patient of, what their risks are, and et cetera. I hope that answers most people's questions regarding estrogen.
That's a great answer. I think it resonates. What I hope will be a theme here this morning is just a real commitment to personalized care. I mean, that's what makes all the difference. Part and parcel in that question, there are a couple about from women who say my cholesterol was normal, and then I hit menopause and it jumped up. Should that worry me? Should that worry me more or less, or does that affect how aggressively I should manage my cholesterol? And is there anything I should do to perhaps evaluate that more?
So yes, after menopause, your body changes substantially. So your cholesterol goes up, your weight goes up, and the distribution of the weight changes as well. And women after menopause, their blood pressure increases, and quite steeply. And so that's quite different on how our bodies respond with respect to hypertension. There's a rapid increase in blood pressure. And going back to the cholesterol issue, again, I think that it depends on how high it goes, what other risk factors you have. But if it is high, you should definitely talk it over with your physician or a cardiologist. And you might benefit from being on statin therapy. Always, foremost, before we try any drug, I think that diet and exercise or lifestyle, which you'll hear about later, is very key in management of a whole host of issues.
Great, that's helpful. There's another theme here, a question of people, are women asking about calcium replacement? Because we hear a lot about the fact that calcium in our vessels is a marker for badness. And if we're taking oral calcium, or women are frequently recommended, does that affect the risk of developing more plaque and getting more calcium in their vessels? Can you comment on that?
That's a great question. And actually, just in it was last week's journal, the Journal of American College of Cardiology, they had two papers addressing that issue. So the calcium, if you eat a high calcium diet, leafy vegetables, dairy, etc., you are not going to get more calcium in your arteries. The calcium in your arteries come because atherosclerosis or lipid plaque attracts calcium. And so, that's why we call it hardening of the arteries. So yes, you can have, this calcium, and unfortunately the calcium doesn't go away once you get the cholesterol down. The data shows that one, the natural calcium you ingest through diet does not affect coronary artery disease, does not increase your calcium in your arteries. There are conflicting data depending on which papers you look at, and some of the papers show that there is an increase in cardiovascular disease, and then other papers don't demonstrate that. I think at this point, just like the estrogens, one has to consider why you're taking the calcium. Now, it's amazing. These papers report that 60% of Americans in the Medicare age, 60%, like every other person, is taking calcium. So, we're a country who loves supplements. But you really have to think, like, why am I taking it? What is my risk for having osteoporosis? Calcium is not without side effects. It causes constipation, could cause a lot of other issues. So my advice is, again, I wouldn't take generic anything, drugs or supplements, unless there's a good reason. And if you have very high risk for coronary artery disease, maybe you should back off on the calcium. If you are very high risk for osteoporosis and low risk for coronary artery disease, maybe it's, maybe you can take it. So again, it's individualized care, and we have to make decisions with the patient in context of what other things are going on.
Jane, that's awesome. It's always an animated discussion on that, and I compliment you on having read last week's Journal of American College of Cardiology. You're one step ahead of me there, and that's why we love you. So there's a question here that actually I don't know the answer to. I'm intrigued at what you're going to say, and that is there a link between heart disease and infertility? Anyone shown that? Anyone looked at that? So,
infertility, you have to look at, that's a very broad diagnosis and involves two people, right? But for the mother, yes, so like women with polycystic ovarian disease, they tend to be infertile, and that is, that syndrome is definitely associated with cardiometabolic syndrome and increased cardiovascular risk. The infertility itself, there's, most of the time these days, infertility for the mother is because we're older, and so there's a lot of supplemental hormones, and there is data mostly from Europe, because they track everybody, and they have a very different objective than studies in the United States. But there is some data showing that excess hormonal treatment, such as an IVF, increases your risk for having cardiovascular disease. So, it's hard to say at this point. I didn't see any data showing that just infertility alone is a risk, but it's, all the treatments we give women for infertility. And just remember, when you are pregnant, all those hormones is a huge hemodynamic stress on your system. Estrogens, massive doses. These are not normal doses that we give when they, physiologic doses when women get IVF. And actually, that was one of the, when I heard this lecture over 10 years ago, I was very concerned because we don't educate our mothers or potential mothers about the possible complications of taking so many hormones.
Wow, that's an interesting answer, and obviously that's probably pretty topical for the area we live in. I think we have an area where women tend to be a little older, and there's certainly the prevalence of IVF
Absolutely.
treatments and things changing. So all the more reason for you to have a women's clinic here and get people thinking about it earlier. Here's another good specific question. This is from a 77-year-old woman who has no known heart disease or history of heart disease. And she was talking to her doctor, and her doctor said she doesn't even need to check her cholesterol after 75. Her cholesterol is actually it's 248. And her doctor said there's no reason to be screened and she doesn't need to take medicine. Would you agree with that?
Well, again, I have to know the details. What's the fractionation? I mean, if her HDL is super high and it's mostly HDL, probably not. And what's her family history? And is she diabetic? She says she's pretty healthy. So, you're 77. Do you still follow it? I would still follow it. I mean, we are living longer, right? And so the whole point is like you want to be totally functional. You don't want a heart attack. You don't want a stroke. And when you check out at 90 or 100, you want to have all your faculties.
Absolutely. Yeah, and maybe you can think? Comment then on. Well, I'll just turn it back to you and say, can you comment on? I always think that statins are a vascular vitamin, and they help with the lining of our vessels, what's called the endothelium, and they help our endothelial just viability, health, and wellness. So, I know we probably give statins out our threshold for giving out is probably too low. On the other hand, I don't think there should be an age limit, especially around here when people are so vital well into their 90s. I mean, I have a barnyard of patients in their 90s who are jumping up and down on a daily basis. So I again, compliment you on trying to personalize your answer. Then there are a few questions about blood sugar and borderline blood sugars. Should we be worried about that as women? Especially, does there tend to be an increase in blood sugar after menopause? And there are now a group of oral agents with increasing evidence that, again, these diabetic agents might be helpful for endothelial wellness. What's your take on that? And where should blood sugar fit into women's thought process as they're managing the risk factors?
So it's really interesting. As we all know, diabetes or even prediabetes is a risk factor for coronary artery disease. And if you have gestational diabetes, that confers greater risk for not just developing diabetes later, but also developing complications as including hypertension, which you wouldn't think is related to the diabetes. But it's probably like this whole, bundle of risk factors that you just carry on. It's like baggage you just carry on. So the interesting thing about diabetes in men and women is that women tend to get diabetes younger, and that's not good because it's not. So you look at the statistics, and the same number of men and women get diabetic, but women get it earlier, so they're actually exposed to diabetes longer, and so they have more complications from the diabetes. Again, I'm a big fan of diet and exercise. I think that, I saw a patient who actually she didn't feel well. She's like, late 40s. She works full time, and like all working moms these days, she's trying to run a household, work full time. She has a disabled child. And, she's, treading water, but she didn't feel well. So she made the appointment to see me, and her hemoglobin A1C was like 12%. I mean, this woman hadn't seen a doctor for years. So it's 12% is super, super high. So it's like, she's almost like, her blood is like, a chocolate shake. But she, so we talked it over. I started her on meds, but she lost like 20 or 30 pounds in just like the last 6 months. Started exercising, got a treadmill out of the garage, and was just like doing 30 minutes a day. And she got her sugars down. So I'm still a huge advocate of lifestyle Dr. St. Gore. I think if we, change our diet, change our lifestyle, we can manage a lot of things. And yes, drugs are wonderful, but I think there's another, exercise is also super helpful in actually, treating the endothelium. And, you and I both have seen patients who have horrible vascular disease, but they're incredible functionally and live long and productive lives. So I think, all these are super important. And again, I think you have to see what else is going on. One of the things I want to talk about, diabetes in women. So, one other thing, and going back to the lifestyle. So, I mentioned that the American public has become, less fit, and it's shocking. Last year's data on like the current status of the American public, 17% of girls under the age of 18. So you're talking about high school girls. Only 17% of girls do any regular exercise. So it's
That's
really sad.
Stunning statistic. That is just
compared to about double that number. The boys aren't that healthy either. I mean,
Yep. So there's a really loud message there.
PE.
Great. Get them all moving. That's move more, eat less. That's how I finish up many of my patient visits. And so, Jane, that was great. Thanks. You really are a wonderful fountain of really important and helpful information. And Jane's going to come back at the end when we get the whole panel together. And also, I want to thank all the people who've submitted questions through the chat room. So keep loading it up, keep passing them on. That'll be great. Next, I want to introduce Dr. Deepu Nair, who is the medical director of the cardiac echo imaging service line here at El Camino Health. Before Dr. Nair talks, I want to point out that individuals who specialize in cardiac imaging need to be real, I would say, visionaries. And what I mean by that is they have to process a variety of very complex two-dimensional images and in their head create a 3D model of how the heart is either functioning or, more often the case for us, malfunctioning. And then they need to be able to communicate that effectively to the rest of us so that we can understand and address it. And honestly, few do it better than Deepu. He really is both a master imager and a master communicator. So Deepu, thanks for taking the time to share with us today an update on innovation in imaging.
Thank you very much, Amy and Fred, for inviting me to speak today. My name is Deepu Nair. I'm the medical director of the echocardiography lab at El Camino Hospital and El Camino Health. And I am here to speak to you today about innovations in cardiology, specifically relating to cardiac imaging. So I like to think of this more broadly. For really thousands of years, humans have been thinking about how it is that our bodies work. And in many ways, we're visual creatures. More than almost half of our brains are devoted to visual processing in one way or another. And historically, the only way we could figure these things out was to dissect and try to solve things that way. But in the past 50 to 100 years, technology has finally allowed us to image the body and the heart specifically in this context with non-invasive means. So today I'm hoping to give you just sort of a high-level outline of some of the cardiac technologies we use to image the heart, which allow us to do some of the amazing things you'll be hearing about during the day today, including by Dr. Ramahan shortly. So I'd like to start with something that's close to my heart here, which is, pun intended, I guess, echocardiography. So echocardiography is using ultrasound technology to evaluate how the heart works. Many of you are familiar with this perhaps from prenatal ultrasounds during pregnancy. It's the same idea, using ultrasound to image the heart, and it's really the workhorse of a cardiology department. And this technology has a number of positives. First off, it's non-invasive, it's fast, it's quite accurate, and it's portable. And the last 10 years have seen a real explosion in the technology that's available for echocardiography. Now we are able to image in real time, three-dimensionally, the heart. And so some of the images here on the top right, for example, is a three-dimensional image of a mechanical heart valve, which is the circular thing there. The two posts are the mechanical leaflets of this valve. And we can image that in real time, which allows us to really think about it in a much more creative way than we did before. The bottom right is a closure device used to close a congenital hole in the heart, and you can see its sort of circular profile. Another special type of echocardiography is called Trans-Esophageal Echocardiography, and this is where we place the probe in the esophagus, allowing us to take pictures while someone is, say, fixing the heart. And this has been used for decades now in cardiac surgery to see how a surgery has gone. We're now using it as part of the structural heart team to look at the heart when we're doing minimally invasive procedures as well. This brings me to the idea of the structural heart team, which really is to find a collaborative team to help with complex procedures. At El Camino Health, we have teams composed of a number of people, only some of whom I've listed here, including a structural interventionalist. This is a cardiologist with special training in minimally invasive valve procedures, for instance, a cardiac imaging specialist, a heart surgeon, an anesthesiologist, nurses, administrative staff, and this whole team comes together in order to provide the best possible outcomes for the patient. Another type of technology that we rely on heavily is CT technology. Historically, when we ask the question, am I at risk for heart disease, what we've done often is stress testing. Many of you may have heard of this or had one yourself. A stress test is a useful test, but it has certain limitations. Using a simple CT scan without contrast called a CT calcium score, we can actually image the arteries, and in that top right image, you can see that we can image calcium in the arteries, which is a sign of plaque buildup. If you have calcium in your arteries, it means that there is plaque buildup, and we should be working on minimizing your risk of future cardiac events. A more detailed type of CT scan is called a CT coronary angiogram, and this is something we heavily rely upon these days. This is a fancy way to image the heart with contrast in order to see the arteries of the heart in a non-invasive way. On the right image here, is a picture from an angiogram, which is an invasive procedure where we inject dye in the arteries. And the left image is actually the same patient, same artery, and the arrow points to the same area of narrowing, which I think you can see the artery looks pinched there. And these types of images allow us to assess the heart arteries without the need to do something invasive right up front. And the accuracy and resolution of these images has really improved over the course of the past decade or so. We can also expand the window of a CT scan and image the whole body. This is actually an image of, on the left, is an image of a person subtracting everything except for their blood vessels and some of their organs. And you can see how we can image the body, and then on the right side, we can slice this image into different planes and make measurements which allow us to design our procedures for the heart. One other important question is whether these narrowings are important. Not every narrowing needs to be fixed, and we use another new technology in partnership with a local company called HeartFlow, called FFRCT. It's basically a way to use computer modeling to model the blood flow in the arteries, and that helps us decide what we should be doing about narrowings in people's vessels. The image on the right, basically red is bad, and you can see in these arteries that there are a number of branches of these vessels which are red, have reduced blood flow, and that helps us decide that this is a patient who might benefit from a stent procedure or a cardiac surgery. So using these new modalities and using these new technologies like echo and CT, for instance, we can image the heart and provide a way to plan for complex cardiac procedures and give the patients the best possible outcome. Again, thank you very much for inviting me to speak today. I look forward to answering any questions you may have.
Wow. Thanks, Deepu. You really are a phenomenal communicator. Thanks for doing that. It's amazing to think how the real-time two-dimensional imaging and the non-invasive functional information that we now acquire has had such a positive impact on our ability to really deliver much more effective cardiovascular care. Back when Jane and I were in our training, we didn't even dream of these innovations. And what's also totally cool is that last little section of Deepu's talk when he was talking about heart flow, that's a technology that in its early days was housed right here at El Camino Hospital. So even though we are a small community hospital, we really have a global impact on the development and innovation of healthcare. So Dr. Nair and Dr. Chad Ramahan, who directs the cardiac cath lab in the interventional program, work very closely as a team. So before Dr. Nair takes any questions, I think it's better that we have Dr. Ramahan give us an update on the latest and greatest innovations that he is working on. And before he starts, I want to point out two things. First of all, we are really incredibly fortunate to be practicing medicine and delivering medicine here in Silicon Valley, because truly it has been the epicenter for cardiovascular innovation. And we all here at El Camino Hospital take great pride in that, and especially Dr. Ramahan, who is very actively engaged in this process. And then second, one of the most important qualities of a cardiovascular interventionalist, one who does procedures there in the cath lab, is how they handle situations when they go off the rail. It doesn't happen very often, but when it does, it's pretty heart-stopping, so to speak. And I can honestly say that there's no one who I would rather have leading a procedure than Dr. Ramahan when things get really ugly. He's truly the master of calm. So thanks, Chad, for your presentation today. I look forward to it. Let's roll it.
Welcome to Heart Forum 2021. My name is Chad Ramahan, and I'm an interventional cardiologist and the director of the Cardiac Catheterization Lab and Structural Heart Program here at El Camino Hospital. I'm going to be talking to you about innovations in interventional cardiology and concentrating predominantly on structural cardiology. What is structural cardiology? It's the intersection between interventional cardiology and cardiac surgery. And we're dealing mostly with valves, muscles, holes. We're not talking about coronary artery disease or stents, bypass surgery, that kind of heart attacks. And we're not talking about electrophysiology, arrhythmias, pacemakers, ablations. We're going to particularly be talking about transcatheter devices. They're minimally invasive and they have minimal morbidity. That means there's not a lot of recovery to them. There's no open heart surgery, no cutting of the sternum, and no stopping the heart and putting your brain on a heart-lung bypass. We're going to talk about aortic valve replacement, transcatheter valve replacement called Tavr, transcatheter mitral valve replacement called MitraClip, left atrial appendage closure. We'll go into those in detail, but we do lots of other things as well, including transcatheter tricuspid valve repair, transcatheter mitral valve replacement. We close holes around surgical valves that have been placed. That's called paravalvular leak closure. And we close congenital holes like atrial septal defects, holes between the upper chambers of the heart, VSDs, holes between the lower chambers of the heart, and other types of holes. Let's first talk about transcatheter aortic valve replacement called Tavr. This is going through your leg predominantly, 98% of the time. We do a puncture wound in your leg, and we take a catheter, a small plastic tube, and bring it up into your heart, and we push out your old valve and place a stent that has sewn in the same pig or cow tissue that's in a surgical valve, and it's working immediately. We don't have to stop the heart, we don't cut open the chest, and we don't put your brain on a pump, and that allows much better recovery. There are two devices that are approved, and we use both of them, the Medtronic Evolute Pro and the Edwards Sapien S3 valve. One is made of a nickel titanium alloy with porcine or pig leaflets, and one is made of cobalt chromium with bovine or cow tissue. We've been participating in the clinical trials and have been the early adopters of this technology. Our first clinical trial participant was actually in 2010. And we were the second site in the Bay Area to do this. We participated in all of the major clinical trials in both high risk, low risk, and the intermediate risk trials. We've just published the most recent trial, which looked at all comers, 72-year-olds on average, that could either have surgery or aortic valve replacement, and people did well. From when we first started doing this in 2010 to now, there's been a lot of innovation. So if you think about surgical aortic valve replacement, that's general anesthesia, a sternotomy, cutting open the sternum, stopping your heart. You're in the hospital for 5 to 7 days, and recovery is 2 months. When we first started doing transcatheter aortic valve replacement, we put people to sleep under general anesthesia. They were in the hospital for 5 days. They had a temporary pacemaker. They had a catheter in their bladder. They were in the ICU. It was in clinical studies. Now, 2021, we do this with sedation, so people are not under general anesthesia. They're breathing on their own. We do it without surgery. It's just a puncture wound in the groin. That's called percutaneous access. We don't go to the ICU. We go straight to the regular floor, and people are on average in the hospital only 1 day. And the clinical trials have shown that it's just as effective as surgery, so it's approved for pretty much everybody who has aortic stenosis. Transcatheter mitral valve repair is a wonderful story because it has a local bend to it. The mitral clip, which is what's been approved, was actually invented here at El Camino Hospital by Fred St. Gore. And we were the one of the early sites in America and in Northern California. We did our first patient in 2009. We participated in all the major clinical trials, the Everest II Realism and COAP trials. This device has been so well received that it actually got a New York Times article after the COAP study was published in 2018 saying, huge advancement for the treatment of severe heart failure. A clip used to repair damaged heart valves sharply reduces deaths among patients with a grim prognosis. So this is a procedure where we go through the femoral vein and we go into the left atrium and we clip the two leaflets together so that they're not leaking and patients improve dramatically. They have less backing up into the lungs, less shortness of breath, less hospitalizations, and actually a mortality advantage. Our patients don't go to the ICU, they go straight to the floor, and our average our median length of stay is 1 day. But MitraClip has actually changed a lot since 2011. There's been advancements in the device. So now there's two sizes of lengths, so longer clip arms to allow for more pathology to clip and having a better outcome. And there's actually wider clips. So we have short, narrow, short, wide, long, narrow, long, wide. And we use on average 1.5 clips. So half the time we use 2 clips and half the time we use 1 clip and are getting great results. The mitral clip is now approved for patients who are at high risk for surgical mitral valve repair or replacement, or in patients who have congestive heart failure, who have used all their medical therapy and are still having symptoms. And then left atrial appendage transcatheter occlusion is a device called the Watchman device. And this reduces the risk of stroke in patients with atrial fibrillation to avoid anticoagulation. Now, atrial fibrillation is a very common arrhythmia. I sort of think of it as like arthritis. As people get older, their heart gets older and they get atrial fibrillation. It's about 20% in people over 80 and 10% in people over 70. And it's the biggest problem with it is the risk of stroke. You have a vestigial part of your heart called the left atrial appendage that has to do with your fetal development of your heart, and it serves no real clinical purpose. And unfortunately, blood pools there, and whenever blood doesn't move, clots can form, and a clot forming there can break off and go to your brain and cause a stroke. And 90% of strokes are due to clot in the left atrial appendage. So most people are given a blood thinning medication such as warfarin or Eliquis, Xarelto, Perdax. I'm sure you've seen ads on TV for all these medications, and they work great. But some people can't take those medicines because they have bleeding complications. And so instead of taking a blood thinner and thinning your blood all over your body just to affect this one appendage, the idea is to close off the appendage to lower risk of stroke. And the top right hand of the screen, you can see a left atrial appendage closure device, the Watchman, in the appendage. And in the bottom right is a Trans-Esophageal Echocardiographic image. And you can see a little round ball in there. That's a clot, which we would hopefully not have embolize up to your brain and cause a stroke. We've been a leader in Watchman device since it was FDA approved 3 years ago, and are the highest volume in the Bay Area with excellent outcomes. We're about to enroll in a clinical trial called the Champion trial, which is going to randomize people who are not at high risk for bleeding to an oral anticoagulant such as Eliquis versus the Watchman, which I think is a pivotal trial to see how this does and help people get off of blood thinning medications. Here's the design of the Champion trial. There are only 2 sites in the Bay Area. And this should be really exciting. The Watchman device has also had some innovations. The newest device is called the Watchman Flex, which you can see is a little shorter of a device and has a little softer end to it, so there's less risk of procedural damage and procedural complications. The biggest real innovation in transcatheter therapies or structural cardiology is not actually a device or a procedure or engineering. It's about how we take care of patients and how we see patients. And that really has to do with what's called the multidisciplinary heart valve team. So historically, when someone had a heart valve problem or a structural heart problem, they would see a surgeon, they would see a cardiologist, they would see an interventional cardiologist, they may see a heart failure doctor. It was multiple visits. Those physicians wouldn't talk to each other, and they give the patient multiple different opinions about what to do. The new paradigm, which is the biggest innovation, is where we put the patient in the center and we all talk together about the patient. And in our program, that's called the Multi-Disciplinary Heart Valve Clinic, where a patient will get an echocardiogram and a CT scan. We'll see an interventional cardiologist like myself and my partners who are cardiac surgeons in the same room with their family. We talk about all their options: medical therapy, cardiac surgery, transcatheter therapies, and we try to tailor what's best for them with their needs and values in mind. And that's really the best innovation that we've had in the last 10 years. Thank you.
Deepu and Chad, those are both great presentations. And what resonates for me in both of these presentations is the fact that we are witnessing some amazing advancements now in medical technology. And we are so fortunate here at El Camino Health to be actively involved in these developments. It's the best therapies truly delivered by the best physicians. I want to come back to Chad's last take-home message, because this really does resonate with me, and that is the power and the effectiveness of a team approach to delivering healthcare. It's so important, and it allows care to be delivered collaboratively and tailored in a very patient-specific way, and there's no question that optimizes the quality of health. All right, let's take a few questions here. The chat room is actually really buzzing. And this is a little bit of a dance to try to figure out. Let's start with some imaging questions. So if we could go to the three of us on the screen, that would be great. Okay. Well, I'm frozen up, but hopefully that's still okay. Good. So let's start with some imaging questions. Actually, before we do that, there was one question that popped in the middle of it that I'm impressed by, and I'm embarrassed that we haven't done a better job of defining it. And someone said, what are cardiac risk factors? We keep talking about cardiac risk factors. Deepu, can you just quickly outline what you think are the most important cardiac risk factors?
Sure, Fred. That's a great question. So we kind of use it casually, and there are a lot of risk factors. Some of them are the things that many of us commonly think are associated with heart disease. So those include smoking, high cholesterol, diabetes, sedentary lifestyle, obesity. Those are some of the common ones that are used and come out in every study as linked with heart disease. Another big one is family history. And that's one we struggle with because we don't always understand the genetics of the reason why it runs in all families. But in any case, I think those are some of the major risk factors. So I'd add family history to that mix as well. There are a number of other minor risk factors as well, but those would be the ones I'd focus on.
Great. So there are a barrage of questions about calcium score and CT. There are several specifically saying people who've been recommended that they have a calcium score. And the question I would have for both of you is that when should that be done and what is the real value and how is that then going to affect the management of the patient? Deepu, you want to start with that?
Sure. I think it's a great question. And it's a very powerful technology. I'm always surprised, in a way we're very good at screening for certain diseases. Men get a PSA, we do mammograms, but we don't do a very good job of screening or understanding or identifying early coronary disease, which is actually the most common still cause of death and morbidity. And we do testing like stress testing, which detects advanced disease, but doesn't detect early disease. So calcium scoring is powerful. I think it's useful, particularly in people who have multiple risk factors of the ones that I mentioned earlier. It's also especially helpful in people who have a family history of early heart disease. So, if everyone in your family had a heart attack when they were 50, you may want to think about detecting the disease early. And I think that's balanced by the fact that there is radiation involved. It is an X-ray based test. And so there's a risk to scanning yourself unnecessarily. You can also find incidental findings that require further workup. So it is a bit of a balance and a discussion with your physician. But I think the more risk factors you have and the more it runs in your family, the sooner you should think about it. And then you should discuss the pros and cons of the test with someone who's experienced.
Chad, what's your theory on calcium scores? Is that something that you have a low threshold?
I totally agree with Deepu. I would just add a few things. The main thing for people to realize is that it's a screening test.
So if you already have coronary artery disease, you've already had a stent, you definitely don't need a calcium score. After a certain age, it's less useful because there's a lot of calcium that happens as people get older. So asymptomatic patients who do, I think it's a great test because it actually converts our population risk. The current ways we try to predict coronary artery disease is with tools that you put your individual risk in a population model and get your risks like a population. And this converts your population estimated risk to an individual risk, which I think is very useful for treatment.
I think I
And
just want to echo that can I echo Chad's last point, which is that I think that's really important, which is the fact that we often, historically, we plug into these equations and that's good for a big group of people. But when you're asking about one individual, it becomes less accurate. So Chad's exactly right about that. That's great.
And Deepu, you showed that totally cool image of the heart flow vascular reconstruction. At what point should a patient consider going to that extent of a study?
Right. I think heart flow and CTA are, so again, Chad had emphasized that the calcium score is a screening test for asymptomatic patients. CT scanning and CT angiography with contrast and heart flow are really tests for symptomatic patients. So tests for people who are having chest discomfort where we're trying to figure out what's going on with them. And the CT scan can help us detect coronary disease. It can help us figure out how significant it is. And then the heart flow is additive on top of that. And may help us decide on which areas are most important to their heart and are causing their symptoms. Heart flow is not so helpful if you have normal arteries. The heart flow doesn't add anything. It's really a test for people who have coronary disease, and it helps us assess the significance of the narrowings they may have. So I would say CTA, CT angiography is really for people who are having symptoms. Many of the same patients in whom we think about a stress test. A CTA might be helpful for some of them. It's, again, more helpful in younger patients than in older patients because as you get older and the arteries get calcified with age, the accuracy of the test goes down. So middle-aged to younger patients who have symptoms might benefit in certain circumstances.
Great. That's really helpful. So no surprise, there are a series of questions here on COVID and the heart. And I think the one question I've seen now several times is from several individuals who, late middle age, both of them, who said they had COVID and have heard that it can have some effect on the heart. And should they consider at some point doing any further testing to look for that? And what would be the threshold in terms of follow-up for that? Deepu, you want to start with that and Chad chime in?
Sure. So I think the testing, there's still a lot we don't know about long-term effects of COVID. So we do know that acutely people can get very ill when they have the initial infection. And some of the illness of COVID, a lot of it is respiratory, as we all know, but there are some people who get serious cardiac complications, including heart attack and inflammation of the heart muscle. As far as long-term COVID, that's still something that we're learning about. There have been a few studies, a provocative study out of Europe, suggesting that you can detect minor abnormalities in many people who have had COVID. Now, the actual significance of that as far as their life and their long-term outcome is unclear. And so at this point, there are no guidelines that everyone with COVID should get routine testing of any kind for heart effects. If you are having ongoing symptoms after COVID, ongoing shortness of breath, chest discomfort, palpitations, then I think those patients maybe should be seen by their internist and or cardiologist. We think that certain tests, including echocardiography and cardiac MRI, might be particularly useful in that patients. A subset. The vast majority of people seem not to develop long-term cardiac complications that are significant.
Great. Chad, any thoughts when patients come into you and have this question?
Yeah, I totally agree with Deepu. I think that the base of the pyramid of the COVID exposure to our country is actually much larger than we think. A lot of people who are asymptomatic and got infected, and then there's a lot of people who had symptoms and recovered, and all those people don't need cardiac testing. So the cardiac testing is really symptom driven. There are rare late effects of COVID on the cardiovascular system. The biggest thing in the hospital has been an increased risk of clotting so strokes and blood clots and those kind of issues. But if the two people you mentioned have recovered and are asymptomatic, I would really avoid unnecessary testing.
Great, that's helpful. I'm sure we're going to get a lot of questions down the road about that, so we have to. Hopefully, we will learn. It's a moving target, obviously, and we're learning on a daily basis. Let's change gears here a little bit. No surprise, there are a bunch of questions about valve interventions, Chad and Deepu. I know you guys are sort of the A team on doing this. The question that has come up now several times here is someone who is in their mid-70s and has been told that they have progressive aortic valve disease. They're starting to feel poorly, and they're worried about whether they need to have heart surgery or percutaneous, and what would be the risk of those various interventions. And I apologize, that's a little bit of an open-ended question, but why don't we try to be succinct on it?
Sure. I think that's a great question, and it's something I see every day. And we are fortunate to live in a time where we have answers. One of the reasons I went into cardiology is we did large clinical trials and we have studies and we can actually give patients answers. And the 70-year-old with aortic valve disease who is having symptoms, we know they need to be treated. So once you have severe valvular disease and you have symptoms, you need treatment. Valve diseases are typically a mechanical problem. They can't be treated with medications. They need a mechanical treatment, especially of the aortic valve. And there's really two types of mechanical treatments now. There's an aortic valve replacement surgically and aortic valve replacement transcatheterly. And we've actually we participated in large clinical trials of patients just like that. The average age of the low-risk Tavr trial was 72. And those data sets have been published out to 2 years and show actually a slight superiority of transcatheter valve versus surgical aortic valve. So improve recovery and actually less bad outcomes like stroke and death. Now, what we don't know is what the 10-year outcomes are going to be, and that's going to be published. These trials are designed that way. But the current national guidelines have made it clear that if the anatomy is favorable for transcatheter aortic valve replacement, even in the younger 70-year-old, the nice thing about talking about valve patients is 70-year-olds are really young. So, we're looking at 30-year life expectancy. And we're trying to think about, how we're going to deal with their valves over the next 25 to 30 years. So one of the tests we do, which is this integration with Deepu's tests, are a CT scan. And the CT scan can help evaluate the aortic valve and the aorta and see the size of the valve, the size of the transcatheter or surgical valve place, and the anatomic variants that make one valve more preferable than other. And so again, we try to personalize it to the actual patient to get the best outcome, whether it be surgical or transcatheter.
Great. Deepu, any thoughts there?
Yeah, I would just add that I think that's great. Chad's really a leader on all of these things. I would say that a lot of these diseases don't come one at a time. So sometimes people have both coronary disease and aortic valve disease and maybe mitral valve disease and then maybe atrial fibrillation. And these problems come in groups. And so sometimes the decision making about what the best option is has to balance all of these things. So we use tests like echocardiography, CT, angiography, and then we have to integrate them and then decide, which one gives the patient the most complete or longest or durable, lowest risk result. And so sometimes it really is about balancing multiple problems.
Great, that's helpful. Well, this is going to be a little frustrating because we have a whole avalanche of questions and I've been given the hook here that we have to keep moving. But I do really want to point out that you two are an incredible team, and the sum is, no offense, but stronger than the individual parts, meaning you as a team sort of set a standard that the rest of us aspire to in trying to take care of our patients. So thank you very much. And I'd like to ask you guys, if you're willing to come back at the end, we're going to do a group Hollywood Squares discussion. And if you guys could hang out and come back for that, that would be really great. But thank you both very much. So now let's transition. Any thought? No. So let's transit. Now, before we do, this is a little bit more the halfway point. I want everyone to stand up. You're at home. Everyone stand up, shake a little bit, jump a little bit, move around. We don't want to sit this whole time. So everyone move. Let's do that for 10 or 15 seconds. Okay? We all doing that? That's great. I don't want to demonstrate that I can sit still for 2 hours. That's crazy. So this next part of the program is going to be really fun. And this is really focusing on what we had wanted to be the real special theme of this year's Heart Forum. And for that, I want to introduce my good friend, Dr. Neil Scott, who's the medical director of the Cardiopulmonary Wellness Center here at El Camino Health. So Neil and I, we go way back. We were several years apart at medical school back at Harvard, otherwise known as the Stanford of the East. But the difference between the two of us was that when I graduated, I was a single doc. And when Neil graduated, he was one of the select brainiac group who were double docs. And what I mean by that is not only does Neil have an MD, but he also has a PhD. And for this, I am truly in awe. So we are really fortunate to have someone here at El Camino with Neil's exceptional academic, wise, and thoughtful approach to healthcare. So Neil, thank you very much for taking the time to speak with us today and for updating us now on the Cardiopulmonary Wellness Program.
Hello, I'm Dr. Neil Scott, and I am the Medical Director of the Cardiac Rehabilitation Program at El Camino Health. And I'd like to take a few minutes to talk to you about the program. First, let's talk about the patients. Who is eligible to enter the program? Usually, if you have one of these diagnoses within 6 months, you're eligible to enter the program at El Camino Health. And the diagnoses are acute myocardial infarction, which is also known as a heart attack, coronary intervention, which means you've undergone a procedure where you've had a stent placed or you've had an angioplasty, coronary bypass surgery, stable angina or stable chest pain of cardiac origin, heart valve surgery where you've had a valve replaced or repaired, or you have a diagnosis of congestive heart failure with a reduced ejection fraction. And that is patients with congestive heart failure because the heart muscle is not contracting as well as it should. Now, most insurance companies and Medicare approve up to 36 sessions of cardiac rehabilitation. And what that involves is monitored physical activity for a number of those sessions, dietary instruction, where there are classes on how important your diet is to your overall health, how to reduce your stress, and also classes on medication instruction, where you learn what medications do what to your heart and how important they are. Now, the benefits of cardiac rehabilitation are vast, and they are very significant on mortality. The study I'm quoting was essentially an amalgamation, it's called a meta-analysis, of a number of other studies looking at the benefits of cardiac rehabilitation. And what they did was they compared patients who completed a cardiac rehab program to patients who did not complete or did not enter a cardiac rehabilitation program. And what they found was patients who completed a program had a 36% reduction in cardiac deaths and a 26% reduction in all-cause mortality. There was, importantly, a 47% reduction in reinfarction. This is in the group of patients who presented with myocardial infarction or heart attack. In those patients who presented with cardiac bypass surgery as their reason for entry, there weren't as many studies performed, but there was clearly a 13 to 40% reduction in all-cause mortality. In patients who presented with heart failure, that is, failure of the heart as a pump, the muscle is not contracting as well as it should, there was a 45% reduction in mortality. Now, for those patients who had valvular procedures, either surgery or repair of their valves, there weren't many studies on mortality. However, there was a clear benefit in the ability to exercise in those patients who completed a program. Now, what happens after your cardiac rehabilitation program is finished? El Camino Health has worked out an arrangement with the El Camino Y, which is right down the block from the Mountain View campus, for those patients who complete a program to have a free 3-month membership to the YMCA. And these patients are also eligible to enter into Dr. Kate Collings' program of health wellness, which you'll hear more about in a subsequent talk by her. Now, what are the future plans for El Camino Health cardiac rehabilitation? We've entered into an arrangement with one of the leading home-based cardiac rehabilitation programs. And most of the data have shown that home-based cardiac rehabilitation can provide many of the same benefits that the in-person rehabilitation program can provide. Also, we'll be starting a cooking instruction and nutrition education program for our cardiac rehabilitation patients that will be available online. And way in the future, there may be an expansion of the cardiac rehab program at El Camino Health into the campus at Los Gatos. So I'd also just like to say thank you to Dr. Catherine Collings and Vivian Lowe. These were the two individuals that started the cardiac rehabilitation program at El Camino Health a number of years ago, and they put together a fantastic program. And also, Julie Arbuckle runs the day-to-day management of the program, and this program wouldn't be what it is today without her input. So I'd just like to thank you so much for spending a few minutes learning about the cardiac rehab program at El Camino Health. Thank you.
Dr. Scott, that was great. Thank you. It's really inspiring, and it really reminds us of how important a cardiac rehab program is. So here's quiz question number 2. How much do we decrease cardiac death if we sign up for a cardiac rehab program after having a heart attack? It's an amazing number. You guys remember what it was? It's 36%. That's a big deal. I mean, it's not just 1 or 5 or 10. So cardiac rehab is really, really important in many, many ways. Dr. Scott's going to come back for some questions in just a few minutes. But first, I would like to introduce Dr. Kate Collings. And just like Neil, Kate and I also go back quite a ways. We did our cardiology training at Stanford just about the same time. And just like I was impressed and envious of Neil's PhD badge of scientific expertise, I was also very envious of Kate, as she came into the Stanford cardiology program having already acquired a deep expertise in exercise physiology. That's something that I, as a wannabe athlete, always wanted to know more about. Wished I did. Now, Kate's been practicing at El Camino community for almost as long as I have, and she has developed an enduring patient population. But along with that, she has been, as Neil mentioned, very instrumental in setting up and then for a long time leading the cardiopulmonary rehab and wellness program. And for that, we and all the community are very, very appreciative of all your efforts, Kate. It's only appropriate then that she has now taken on the challenge of setting up a lifestyle management program here at El Camino Health. When it comes to the health of a community, honestly, there is nothing more important than lifestyle, whether it's nutrition, sleep, exercise, stress management, relationship management, whatever, you name it, nothing compares in importance. So the program that Kate is establishing will clearly have a huge impact on reducing the overall risk of disease in our community. So Kate, thank you very much for sharing your thoughts on this.
I'm delighted to be part of the Heart Forum again this year. I'm Kate Collings, and I've been a cardiologist with El Camino Hospital and El Camino Health since 1993. And El Camino Health has grown tremendously in lifestyle services since that time. You heard from Dr. Scott, who told you about our Cardiopulmonary Wellness Center, which is shaped for patients after a cardiac admission or diagnosis or procedure. And I'll be talking to you about a relatively new lifestyle medicine services that I'm serving as director for in today. But we also have the South Asian Heart Center, which focuses on the unique needs of South Asian patients, as well as a diabetes prevention program. The importance of lifestyle in disease prevention and extension is really not a surprise to any of you in the audience, but you may not be aware of just how important it is. In this table that comes from a report from the U.S. Burden of Disease Collaborators, dietary risk is the #1 risk for disability and actually for death. And if you look at the top 10 of these risks, 9 out of those top 10 are lifestyle related. And we know in other reports that 80 to 90% of healthcare visits and healthcare dollars are related to conditions that are rooted in everyday lifestyle habits. And there is just enormous research in the basic and clinical sciences to help us understand how our everyday habits and choices lead to lifestyle-related diseases. This infographic comes from a recent summit in which subject matter experts and thought leaders in respective fields of the nutritional sciences, exercise sciences, the sciences around stress management, addiction and sleep, as well as mental health, all convened to look at what are the basic scientific mechanisms that lead to these lifestyle-borne diseases. And you can see on the left side, I believe it's the left side of your screen, that there's some fascinating molecular processes and biological processes that go in and share a common source of whether they alter the microbiome, and many of you may have heard about the microbiome at this time, whether they alter the DNA expression through epigenetics, or whether they lead directly to cell injury and stress. And then all of these mechanisms end up with increase in inflammation and lead to the lifestyle-related diseases that we so commonly think of as age-related. And so you can see at these different places that lifestyle interventions can help not only in prevention, but also in folks that have active disease or even life-threatening heart disease in some situations, to really impact on these basic biological mechanisms. And this summit also convened to look at what were some of the best research methods for us to gain more and more understanding about this over time. So lifestyle medicine may feel like a new thing to some of you in the audience, but it is a now certified specialty since 2017. And there's a great deal of interest in health systems as well as practitioners. At the national level, the organization has grown in its membership over 700%. So trust me that you'll hear much more about lifestyle medicine in the years to come. Lifestyle medicine practitioners focus on these 6 domains or 6 pillars of lifestyle intervention by prescribing nutritional interventions, exercise interventions, helping people with sleep management, stress management, recognizing the importance of relationships and social connections, and so forth. So lifestyle medicine really is a very holistic and whole person approach to care. So in addition to heart disease, lifestyle medicine treats a broad array of conditions. And some of these you know well: prediabetes and diabetes, hypertension, high cholesterol and lipid disorders, fatty liver, cirrhosis, cancer and secondary prevention and cancer survival, as well as patients that are burdened with polypharmacy and many medications. Lifestyle medicine also has a role in autoimmune diseases and plays a distinct role in aging and cognitive approach to the importance of cognition. So now I'd like to share with you what we're doing in our lifestyle medicine services at El Camino Health. We start all of our patients with an MD consult. And this is so important because we really want to understand what the patient's concerns are and what their medical conditions are. And then we take a deep dive into understanding their lifestyle patterns. And we do that through a development of a lifestyle profile. We then co-navigate with the patient. What is the best way that we can serve them? Do they need one-on-one attention? Would they flourish in a group program? And this is an example of our lifestyle medicine assessment. And this is just one of many patients that's taking a detailed look at the patterns of eating. And after we have that lifestyle medicine assessment, we determine with the patient if they want help in an individual one-on-one basis or in a group facilitated program. We take a health coaching and a team approach so that we have a very cohesive treatment plan and patients can really feel like they are under one team's care. We use tech when it's appropriate. We have a meal planning software platform, recipes, and so forth, as well as the ability to use a lifestyle tracking so that patients can see their progress in our program. And then we also utilize culinary medicine and really teaching people how to not only eat the best foods, but prepare in the healthiest ways. We have our nutritionists do food as medicine classes, our exercise physiologists to do exercise as medicine classes, as well as stress management classes. This is an example of the lifestyle profile that patients receive. This is just one page of many. It's a comprehensive profile, and it really allows patients to see when they're in range or out of range. And this is, similar to what we think of as the comprehensive blood panel. So when we have this comprehensive lifestyle profile, the blood work, we know the patient's conditions, then we can really know how to navigate. This is an example of our customized menu planning, which is really personalized to each patient based on their culinary skills, their desires, their taste profiles, their budget, and everything. So we start with an MD consult and, of course, follow-up. We personalize and tailor the approach, offer additional classes in culinary medicine, food as medicine, exercise as medicine, and stress management. So thank you for your interest and attention. I want to leave you with the knowledge that regardless of whether you're wanting to prevent disease, or if you're in an active heart disease, or if you have active heart disease, or even possibly life-threatening disease, you have the power to change your health destiny. Just reach out for help.
Thanks, Kate. That was great, really informative, and congratulations on setting up this program, which is clearly going to have a major impact on our community. Thanks for basically spotlighting that the choices we make every day clearly have a dramatic, direct impact on our health. So let's now get Kate and Neil back up here with me, and see if we can field some questions. There's really been quite an avalanche of questions. No surprise, this is the hot topic, you guys. And so thank you for teeing that up, and we'll see if we can decipher through them. Why don't we first of all start with cardiac rehab? I mean, you guys both have a lot of experience with that. We've had a group of questions of who should come into cardiac rehab, how do they get in, what is the duration of the whole program, and then always the question, who pays for it? Neil, do you want to start with that? And Kate, you can then fill in with your expertise.
Yeah, I could start with that. That was summarized on my first slide. So patients who've had a heart attack, a myocardial infarction, patients who've had a procedure that Chad would do, either an angioplasty or a stent, patients who've had bypass surgery.
I can chime in.
Yeah, why don't you chime in here?
Okay.
That'd be great.
So patients who had bypass surgery, would be, shortly after, 3 to 4 weeks after their surgery. Patients who've had valve surgery, and as Neil said, patients with heart failure. But I would also say one of the conditions that we often don't receive referrals for is patients with what is called stable angina. And maybe they had a procedure and they're not going back for another one, and they still have chest pain now and again. They're actually still eligible for cardiac rehab. And also I would say that sometimes patients are referred early after a procedure, maybe don't come in because of extenuating circumstances, but they can still be eligible for up to a year after most of those procedures. So even if they don't come in right afterwards, or even if they haven't had a procedure and they have stable angina, they're still eligible for cardiac rehab.
And how long does the program go for then?
Go ahead, Neil. I think you're back on. I'll let you take over now.
I'm having trouble here. Up to 36 sessions, and usually it's 3 times a week for 12 weeks. But because of COVID, we've had to decrease the number of spaces available just so we could spread out everybody. And the number of weeks have been shortened from 12 to 8 in most cases. And Julie's around. Julie can do that also.
Yeah, and what do you guys do once they finish the program? How do you sort of follow up and make sure we all continue to do what we're supposed to do, and all the great information that you share with them really is then continues to be applied in their daily lifestyle? How do you follow up on that?
Let's bring Julie in. Is she here?
I can comment on that. When the patients leave, they have a discharge interview and are set up with their plan, for follow-up and maintenance. And they can, of course, still come back to the nutrition lectures, the stress management lectures, and then, of course, they have the YMCA as a beautiful transition to their independent exercise. So there's still a lot of resources for patients after they graduate.
I think as we get back to a little more normalcy, this transition into the YMCA, I always see my patients over there having finished the cardiac rehab. So that's a great setup to transition that. All right, let's transition into lifestyle medicine. You gave us a great overview. I guess the question then comes up is, who should get involved in our lifestyle program? How is it patients who already have heart disease, who have a family history? Kate, who would you really like to see coming, and how do they get into the program?
Right. So patients can get into the program either through a referral from their physician, but they can also, in many cases, self-refer. So patients with PPOs or Medicare can self-refer into the program. And again, that starts with a consult to see the patient and determine, what are their needs. So I think patients, 80 to 90% of our heart disease patients should come to our program, even after they finish cardiac rehab, because we know that lifestyle change, sustaining lifestyle change doesn't just happen in weeks or even in 36 sessions. It's really becomes much more sustainable when people have support over a longer period of time, 6 months, 9 months, a year. So patients who are worried about heart disease in their family would be excellent candidates. Anyone who's being watched for heart disease but hasn't needed any procedures and so forth and hasn't needed to go to cardiac rehab would be an excellent candidate. And certainly anyone with elevated cardiovascular risk, so those with high cholesterol, hypertension, diabetes, which is a heart disease precursor, of course, and so forth, are great candidates for our lifestyle medicine program.
So I've had a couple of questions that just came in from 2 different individuals who say they have atrial fibrillation. Does that interfere with their opportunity either to get into cardiac rehab, or because of that, should they have a lower threshold for going into lifestyle medicine? What is the risk involved with that, and how does that fit into the 2 programs?
Sure. So atrial fibrillation itself is not an eligibility criteria for cardiac rehab. But certainly atrial fibrillation has some correlates in lifestyle. One of the more obvious is sleep apnea and sleep disturbance. Another, which may be related, is stress management. Maybe not such hard data in that. Certainly weight management issues are a provoker of atrial fibrillation. So there's no doubt that patients with atrial fibrillation can benefit from an improvement in lifestyle.
That's great. And Neil, are you back on here?
I'm back.
Great. So
At least for now.
Neil is the master maven of the best diet. You have been lecturing to us for years, and I think my diet is better because I sit in a desk right next to yours, and I always am able to pick your brain and also be reminded by you that diet is one of the most important things besides exercise and we can do. What's the latest and greatest on, there are a couple here on Mediterranean diet. In fact, one person said, I'm on the Mediterranean diet. Does that allow me to come into rehab and to come into the cardiovascular wellness program? How does that interfere, or is that all that you would do? Give me your thoughts.
Well, the data surrounding the Mediterranean diet are overwhelming. It's a diet that's been studied since the early 1960s and clearly has been to markedly decrease.
All right. Well, that's going to just leave us. That's what we call a teaser, Neil. That's a teaser. We're all excited, and maybe we'll get more about that later. No worries. This is going great. And Kate? Do you have any comments on diet in particular? What do you advise people these days?
Sure. So, my advice is generally around a plant predominant diet, and certainly of the diets that are out there, Mediterranean falls into that category as well. And whether it is some other diets that have had great data include the DASH diet or the portfolio diet or whole food plant-based diet. And what's key in all of these is that there's an abundance of, fruits and vegetables, whole grains, beans and legumes, and nuts and seeds. And so, whether that goes by the Mediterranean title or goes by the DASH title or the portfolio or the whole food plant-based, that common theme just resonates through all of our nutritional studies.
Great. So there's another theme that I've been asked here a couple of times today in this avalanche of questions, and both of you probably can comment on that. And it's actually the amount of exercise one should do, and this whole concept of training for performance versus training for longevity. And there's been a lot of discussion about that in the literature. And Kate, as an exercise physiologist, what's your most recent take on this? Because it seems to be evolving a little bit.
The data for longevity versus cardiovascular health?
Well, the concept of you don't want to overdo it, but you need to push yourself clearly to a certain point. There is an optimal level of exercise for longevity. And the reality is for younger people that who are really focused on performance, that may not be the same equation for activity. The concept of putting yourself out of your comfort zone regularly if you're training for performance, whereas for longevity, there's clearly, I think, and you can support me or correct me on this, there's data to say just pushing yourself to the edge of your comfort zone, and you don't have to do it even that much. I think that's what I'm always impressed with is the little amount of regular exercise we need to do that has a really significant impact on our overall wellness and longevity.
Right. Well, so the best exercise is any exercise at all, for sure. That's sometimes when people worry about, having to get their heart rate to a certain level or having to do it so often or having to get really sweaty and uncomfortable, that can be an obstacle for them moving forward. So I think a couple of things that I would emphasize, and maybe not actually, answering your question exactly, Fred, is, even small amounts of exercise multiple times a day, if you can't combine it all into one great exercise session, has amazing health benefits. Getting your heart rate up of any amount and standing up every hour and moving around has, mortality benefits and health benefits. And then the concept that there overtraining, there you go, that's right, that there can be overtraining. I think that that's very important in COVID times myself, because when we talk about immune function, moderate exercise is the sweet spot. 20 minutes of moderate exercise gets you an improvement in immunity for about 12 hours in recent research. Moderate exercise also augments the antibody response to vaccinations, which is really cool right now. But really high intensity exercise has been shown in many studies to suppress immunity. So I think in COVID times, now is not the time to push it. And I know that that's not directly answering your question about the dichotomy between aging and so forth, but I'd be interested to get anyone else's input on that.
No, I mean, I think that you're saying it there pretty clearly. I mean, there's, more probably is better, but not too much. And I also, and I'm sure both you and Neil probably recommend this, and Neil chime in here, but just the importance of individuals listening to signals their body is telling them. I mean, we are inherently all lazy. We are tuned to be lazy. But we need to push ourselves a little bit out of the comfort zone, but not too much out of that. What do you think, Neil? What do you recommend?
Yeah, I think what you're alluding to are the latest studies showing that in elite athletes, especially distance athletes like cyclists, marathon runners, rowers, there's a higher incidence later on of atrial fibrillation. And that I don't know the mechanism of, but it's thought that it may be due to scarring in the atrium from all of the intense activity. But that's what you see, that's what can be seen rather in elite athletes, sort of like you.
I don't think I have to worry about atrial fibrillation. I wish I had done that much. But all right, well, that's great, you guys. Thank you both for your expertise here. And let's see if we can now have the technology to open up this to the whole Hollywood squares of stars here and pull everyone up on. Look at that. That's great. Thank you very much. So we also want to add, there's a new face on the screen here. That's Julie Arbuckle. Thank you, Julie. So, and your name has been mentioned now several times today. And she's the clinical manager of the cardiopulmonary rehab program. She's been incredibly influential. And Julie, thanks for all you've done in building this program really from the ground up. So one of Julie's claims to fame, and she reminds me of this quite regularly, is that I now have been working at El Camino for 30 years, but she has one-upped me. She's been here for 1 year longer than me, and it's really impressive. She's done an incredible amount for the community as a nurse and then transitioning into the cardiopulmonary and building that program. So thank you very much. But one of the most really impressive things about Julie is she not only talks the talk, but she walks the walk. And what I mean by that, she's clearly one of the most athletic individuals in our community. So Julie, 31 years, what's that been like? Have you seen a few changes here at Health? What sort of resonates with you?
Yeah, so thank you very much for that nice introduction, Fred. And I feel so grateful to be part of such a great healthcare system. And I would say probably the two biggest things I've seen over my 30 years, 31 now, are two things. One is that El Camino, even though we're a community hospital, really strives on staying on the cutting edge of innovation for cardiovascular health. And the executive team and the physicians they brought in, it's just, our community should feel very comfortable in what we provide for them. And then I think the second big thing that I've seen over the years that I've been here is really focusing, I think it's been a theme that everybody said today, is that really putting the patient in the center and really individualizing the patient's care. I know that in cardiac rehab, we do that same thing. We work with the entire healthcare team. We're in touch with cardiologists as we need to be. We get a lot of great support from HCI, from Dr. Scott. But we really design an individualized treatment program for our patients, which includes not only the exercise portion, but also the nutrition education. We have a full-time dietitian that our patients get to meet with, which we also along the program. And then we do tap into that stress management part of it. As we know, that stress does have an impact on cardiovascular disease. And I think for a lot of years, we didn't focus as much on that. And I think we're finding out, especially in Silicon Valley, that it really does play a role in cardiovascular incidence and risk. And for those that are out there listening that have had a cardiovascular event, I encourage everyone to come to the program. It's a great educational experience, but it helps you get back to your quality of life. And you'll find it's actually really fun. We have a really good group of team members that work with you, and I think it's a great experience.
Great. That's great, Julie. Thank you. And honestly, thank you for all you've done. So we have a whole avalanche of questions, and I want to send a thank you out to everyone who sent them in. But before we start, what I thought would be kind of fun and to work our way around this Hollywood square of stars is take a case story, and let's tell the story of a 63-year-old woman who has basically enjoyed good health, doesn't have a lot of significant cardiac risk factors, and recently, as she's been out exercising, she's been noting significant shortness of breath and even had a few episodes where she gets a little dizzy and some pressure in her chest. So this woman presents to you, Jane. What kind of conversation would you have with her? And then what next steps would you take and move her then? And we can perhaps move around the whole square and each person could comment on their amount of their expertise in the management of this case.
If she calls us, we will see her right away. And of course, we will, I'm the only person there right now. I will get a history of physical and examine her, get an EKG. And, she sounds like she may have some cardiac symptoms. Certainly,
she has a very loud heart murmur. Very loud heart murmur.
Okay, so thank you for filling that in. So then this directs it more towards like maybe she has a valvular issue and she may have, if she's short of breath, and then she may have some heart failure. And of course, you get an EKG and I would get an echo. Echoes are fabulous. The technology has gotten so much better now, and even the last 5 years, you can tell a lot. So Deepu, you want to comment on what we would see, sort of 63 is young. Young woman with a murmur and symptoms.
Sure, yes. So this would be, well, with the murmur, we were certainly considering, like Jane said, valvular heart disease. And in someone that age, the most common valvular problem would be a mitral valve problem, though aortic valve problems could be there as well, or any other valve for that matter. And what we would be doing is, with an echo, we can assess all of the heart valves, and we can see what the problem is, most likely. If there were questions on transthoracic echocardiography, or if we were suspicious, I had mentioned trans-esophageal echocardiography. That's not usually necessary, but mostly the transthoracic will show it for most people. Also, she had some palpitations, and arrhythmias can be associated with valve disease, and so we probably want to check her out for arrhythmias as well, maybe some type of heart monitor for that. And then once we have the info, we may then be able to talk to one of the structural team or other folks, and maybe Fred can guide us from there.
Yeah, so it turns out when you do your echo, Deepu, she has a strong heart, but she's got a lot of calcium around her aortic valve, which is a surprise. And she has clearly an elevated velocity jet. Maybe you can comment on that, and a valve area of 0.7 centimeters squared. That's what your findings are. What do you think about that, and what might you do next?
Well, so we were going down. So we were talking about aortic valve as a possibility, and so someone at that age, with aortic valve, calcified aortic valve disease usually has a congenital problem with their valve. They were born with a bicuspid valve, meaning that their valve has 2 leaflets instead of 3, most likely. And that valve tends to wear out when people are somewhere between 45 and, say, 65 or so for many people. And so this would be someone who has aortic stenosis or narrowing because of most likely a bicuspid valve. And with imaging, we also want to image the aorta because it often is associated with abnormalities of the aorta as well, congenitally, and those can be progressive over time. So once we got all of that information together, then we would have to talk and evaluate whether she's someone who needs a procedure to fix her valve and or her aorta.
So would you consider, given what your findings are, maybe moving her here to the right of the screen, passing her on to consultation with the heart valve team and
I would pass her over to Chad over here. I'm pushing her over to Chad.
We would see here in our multidisciplinary heart valve team. I think the people you're not seeing on the screen are great cardiac surgeons. So we have 4 great cardiac surgeons here, led by Pei Sao, who's the director of our cardiac surgical program. And Amy mentioned to you guys earlier that we have a 3-star rating for valve surgery at El Camino Hospital, which is actually the highest rating, and there's only 2% of the country has equivalent outcomes as us. So we have a team with me and one of the cardiac surgeons, and we discuss, most likely we get a CT scan to really fully evaluate the anatomy of the valve and the ascending aorta. Sometimes people with bicuspid aortic valve problems also have enlarged or dilated ascending aorta. And then we most likely in her age group be talking about open heart surgery to replace the aortic valve. But even that has changed a little bit because of the technology with transcatheter valves. Probably 10 years ago, we would offer her a mechanical aortic valve, which would be requiring anticoagulation. But now in people in their 60s, we would usually put a surgical bioprosthetic valve, a pig or a cow valve. And then in 10 or 15 years, when that valve wears out, we'd set her up for a transcatheter valve, which can be placed inside the surgical valve, which is new compared to how we would do this 10 years ago and allows the patient to be off of anticoagulation for her life and only have one open heart surgery. And so it's, even if we're not doing transcatheter therapies now, it actually helps to have this conversation in a multidisciplinary valve center.
That's great. So she undergoes open heart surgery, she gets a new valve, and then Julie, at what point would she come and spend time with you?
Yeah, so because we have such great referral rates from our cardiologists and support, I would referral in my database, and one of my staff members would call within 4 to 6 weeks, and we would bring the patient in for an orientation, and then we would start her in 3 days a week and put her on an exercise program based on her diagnoses and maybe her past exercise history, and then we plug her into the nutritional education, and we would put her into the stress management. Regardless of whether people have coronary artery disease or not, we still think what you put in your mouth and how you deal with stress is important for anybody. And then we would set individual exercise goals for her as she progressed through the program.
That's great. And Neil, would there be any physician oversight of this, or would there be a chance you might see this patient or interact with her when she's in cardiopulmonary rehab?
Yeah, every patient that comes in meets the medical director for their first actual visit. So we see them then, and then, we drop by from time to time. But mostly, Kate has set this up so that this is run mainly by the nurse manager, and they do a great job. So Julie would be the day-to-day contact for this and all the other patients.
Right. And you're there if something goes off the rails, and the good news is that rarely happens, isn't it?
Yeah, which rarely happens. Right.
So Kate, would you want to see this woman while she's still in rehab, or when would you find it would be important for you to get involved in sort of looking at the long-term trajectory of her health and wellness?
Right. So, we didn't talk, her condition is not a lifestyle-borne condition, right? She came in with a congenital condition that progressed over time. So we didn't really get the history of if she has other conditions which are more lifestyle-borne.
But she's pretty
Does she?
uptight. She just had heart surgery. She's really nervous about that, and she's worried about that's going to affect her health and wellness. Would you possibly get involved in that or give her recommendations?
Julie and I would work together. Julie, Neal, and I would work together. And if Julie feels like she needs, additional attention after cardiac rehab, that's exactly where she would go. The patients are all given information about our lifestyle program. And for many of them, our group program would be ideal for her because it provides her with a great overview of how to avoid any other future such conditions or events and gives her ongoing support as she makes that full recovery from her surgery.
Great. Well, I'm really impressed. This clearly is a team effort here. And again, that's kind of what our theme is at El Camino Health is, approaching patients in a very patient-specific way, but addressing it as a team. And as I said, that really optimizes the care. So we have had a series of questions of concerned individuals who feel that during this last year, they have been unusually sedentary. No surprise. They've been homebound much more than they want to be. And maybe we could go around and each chime in at what your recommendation might be for how do they change that? And what should they do in terms of an evaluation? And I know that's really hard as a general generic question. So maybe each of you could maybe choose a sort of a specific patient situation and what your recommendation to be. Jane, can you start with that?
Sure. I'm a big believer in exercise. I think it solves a whole host of things. And actually, for me, during COVID, exercise has been easier because we have been doing a lot, you don't have to commute. So for the average patient, though, who's not so lucky to maybe live in a nice place in, where you can go out and walk or bike, I think that, walking is always great. And now that there's a lot of data showing that going outside is pretty safe, and even without a mask, it's the volume of air that you are surrounded in and are expelling. That's important. Walking is always great. You don't need any equipment. So I would start out with that and build it up. I have a dog, so I am obligated to walk at least 3 to 4 miles every day. The dog walks you, not the other way around. So that's another thing. I think a big part of exercise is that it's hard to do on your own. So if you can set up some sort of a social system, a walking buddy, the dog or whatever, and then put it part of habit. If it's part of habit or, then it's much, we rarely forget to brush our teeth when we get up in the morning because it's habit. You do it every day at the same time. And I think with exercise, you should just implement it into your routine. That's how I would approach it. I think people always ask me, what kind of exercise should I do? I always say, do the kind of exercise you enjoy most.
Right.
I'll pass it on to the next person, I guess, is Deepu.
Deepu, maybe you can comment a little bit. Maybe you can elaborate. I mean, you're the ACE master imager, and some of these people are worried getting back into exercise, whether they should do any type of evaluation, and in whom might you advise that versus just saying go out and start walking or start running? What would be your threshold?
It's a good question. I would one other comment is I think some people are intimidated by the idea of when they're getting started first about exercise as a term. And I try to sometimes start by telling people that, just being active, not trying to avoid prolonged sitting, parking farther away, take the stairs, adding activity during the day, consider getting a fitness tracker and just making sure you're moving and not sitting all day is a place to start, and not just get so focused on the idea of exercising for 20 minutes all the time. But as far as imaging, I mean, most people do not need any kind of special imaging before getting routine exercise. So I would encourage everyone to just start walking. And the exceptional situation would be if you have some symptoms that prevent you from walking. Everyone's going to be a little short of breath when they start walking because they're out of shape, for example. But if it seems like it's severe, or if it's preventing you from doing what you used to be able to do a year ago, and it's getting progressively worse, or you have other associated symptoms, then you should see someone. But for the vast majority of people, you don't need a stress test. You don't need anything special. You can just start walking and gradually ramp things up. I think it's important to take your time and build up your fitness.
That's great. So, Chad, sort of to develop on that, I've had a couple of questions from people who said, well, sort of in two lines. It's about COVID vaccination, and to bring it down to something pretty topical. And a couple of questions from older patients saying they're worried, they have heart disease. Should they worry about COVID vaccination? And then maybe you can answer that. And Julie, the question also comes up is, gosh, I've had my vaccination. Should that interfere with my health and wellness program for 2 days, 5 days, a month? I mean, people are, there's a lot of information and disinformation that's sort of bouncing around about that. Chad, how do you answer those questions when patients come to you?
Yeah, the COVID vaccine question is easy. So if you have heart disease, you shouldn't really be worried at all about getting the COVID vaccine. You should get the COVID vaccine. In fact, you are at higher risk for having complications from COVID if you get COVID, if you've got coronary disease. If you're over 65, 90% of the people who've died of COVID in the States have been over 65. So really, you just need to get the COVID vaccine and not worry about your cardiovascular condition. I think that's what you asked me, Fred.
Yeah,
Or something
that's
else?
good. No, that's really helpful. And then, Julie, should that have any effect, even just for a couple of days? I mean, someone got the COVID vaccine yesterday. Are they allowed to come in, or today, and they're coming into rehab? Are you letting them do their exercise that day, or what are you recommending?
So our recommendation is, one, get your vaccine when you can. So vaccinate. Two is it's all individualized. You got to go by how you feel. Some people get the vaccine and they're fine. Some get it and they have a little bit of symptoms. So if you're not feeling well, your energy feels low, those kind of things, I'd say take a few days off. If you're feeling okay, absolutely exercise. And the other thing I wanted to say too is walking's a great exercise, but I just want to give a little plug in for strength training too, especially for postmenopausal women. It's really important to keep your lean body mass. It does a lot for core strength. It does a lot for metabolism. And it's easy to do. You can do body weight activity. You can buy weights at Target now. I know initially when COVID hit, everybody freaked out and you couldn't find them anywhere. But soup cans, you can use things around your house. So don't forget the strength training part of it. It's important.
That's, Julie, that is a great comment. I hope that resonates with everyone and really pay attention. The weights were kind of like toilet paper early on. You couldn't get them. We tried to get them too at our house. So no surprise, Neil and Kate, there's been a slew of questions about blood pressure and the threshold for managing it. And Neil, and what in particular, maybe you can answer this and transition over to Kate. There have been two people asked about their question/concern that their physicians seem to now be slightly more reluctant to start blood pressure medicine, and they're working with a lot of different ways versus medication. What's your approach to that, Neil? What's your thoughts?
Personally, well, the data show that the lower you can maintain a blood pressure, the lower your cardiovascular complications. So I like to keep my patients well controlled. I have a habit of trying to decrease the number of medications that my patients are on to control their blood pressure by ramping up their lifestyle, decreasing their sodium intake, increasing their exercise, trying to convince them to lose weight. And you'd be surprised how big a change that can make. So that's more or less my personal outlook on managing hypertension. Kate, you have any differences?
And Kate,
No,
can you
I would-
comment on, can you comment on the difference between men and women with blood pressure? I get that sometime. Are there any differences in how aggressively you should manage them?
No, I don't believe there are differences in how aggressively to manage them, although they will have, I find that certain blood pressure medicines have more side effects in women than in men in some situations. And so, again, kind of personalizing it to the patient is really important, and not taking a one-size-fits-all approach. But I would just chime in with Julie and Neil and the others in just really specifying the importance of both weight-resistive training as well as cardiovascular training for patients with hypertension and heart disease. And, the U.S. guidelines are for 150 minutes a week of moderate cardiovascular type exercise, which of course can be walking, but also 2 days of weight resistive training. That's our sort of basics. And many of the patients that we see in our program have weight management problems. And so I always like to let people know that when it comes to weight management, really diet is the single most important thing, but exercise is right behind it. But for that long range and getting off that teeter-totter of weight up and down and weight up and down, you really have to get into the exercise, and you really have to stretch out that duration, to 280 minutes or 300 minutes a week. So it doesn't have to be done overnight. The first focus should be on food and eating, and then the next focus coming in right behind it should be on exercise for that sustainability factor.
That's great. I love this resonating theme of exercise. I get reminded at home by my wife, who's an exercise physiologist, that muscles are actually a pharmacy. They produce elements that help the rest of our body as we exercise. They help our brains, they help different organs. So there's really no better pharmaceutical therapy than exercise, thanks to the production of what our muscles can do. So, Jane, why, and this is a question again came up pretty simply, and I think it's important, is why is high blood pressure bad? I mean, we get told, we tell our patients all of that, but then I go, it's silent. I don't notice blood pressure. Why should I worry about it, Jane?
Yeah, so it is silent. So it's called the silent killer, because people actually feel worse when their blood pressure, if you're used to a higher blood pressure and all of a sudden your blood pressure is low, they complain they don't feel well. But blood pressure, so it's two things. One is how high it is, and the other is how long that your body is exposed to that pressure. And high blood pressure is bad because it increases, you just think about it, your brain, your kidneys, your heart are all exposed to this high pressure. So in the brain, you get stroke. In the kidney, you get renal failure. In the heart, you can get hypertensive heart disease, which is, your heart is one giant muscle, as Dr. St. Gore says. And if it's trying to push against a lot of resistance, which is the pressure, it gets really thick, just like any muscle that goes through, weight training. And when it gets really thick, the cavity in your heart gets smaller. It's because it's filled with muscle. And, there's less place for the blood to go to. And that's why a lot of people who have high blood pressure, as they get older, they get into heart failure. That blood has to go somewhere, so it backs up into your lungs. And there's another difference between men and women here. So yes, women, we're smaller. We get hypertension, a huge jump in your blood pressure after menopause, and it's a steep jump. And because we are smaller, a lot of the drugs we have to use less drugs because we're more sensitive to the side effects. But at the same time, when we live longer, exposed to high pressure, we have small hearts, and then that small heart gets smaller. So older women are greater risk for heart failure. And so there's a lot of things going on. And somebody was commenting, or somebody in the audience was asking, what is, how low should we target? And I think it's, the optimum is 120, but, for some patients, you're going to be on a lot of drugs. So that's probably not ideal, but I think we should go as low as the patient can tolerate with as few drugs as possible. And the other thing about exercise is that it lowers your blood pressure. So there you go.
Good. There's a theme here. Good theme. Thanks. So, Deepu, we've had a few questions in an area that we didn't cover today, and that is specifically electrophysiology, the electricians who deal with the irregular heartbeats and when the heart is going either too fast or going irregularly. And my question to you, and it came up several times, is what is your threshold for engaging one of your electrophysiology, cardiology counterparts in their care? I mean, what is that now, and has that changed and evolved over the course of your professional career?
It's a great question. So we're lucky at El Camino to have a number of very busy and experienced electrophysiologists. These are the subspecialists who do cardiac rhythm management. They sort of people have disorders of their heart rhythm, need pacemakers or defibrillators. In my own practice, so it's a very common thing. I mean, people have palpitations very often. These days, it's because they're stressed and COVID and they're not sleeping and they're working from home and their kids are driving them crazy or something like that. But sometimes it's that there is really a problem going on, that there's an arrhythmia of some kind, atrial fibrillation we've mentioned several times, but there's a long list of other arrhythmias. Or in older patients, they have problems with slow heartbeats and they're dizzy or lightheaded. These kinds of things come up quite often. And so once we get to the point that someone might need a pacemaker or a device placed to help their heart rhythm, or that they might need an ablation procedure, which is a procedure to go in and zap the trigger spots for their arrhythmia, that's when we engage the electrophysiologists. And those are, nowadays, the thing that's changed really is that these procedures have gotten, like the theme for today, is that technology has really progressed. And so ablations that used to be 6-hour, 8-hour long procedures with a lot of general anesthesia and long recovery have become more straightforward because of advances in technology. So the mapping catheters, the catheters themselves, the experience of the people using them have all gained quite a bit in the past decade. And so the efficacy of the treatment is much better than it used to be. So I engage them earlier than I used to because they have a lot to offer these patients, our patients.
So that's great. I think we really are very fortunate here at El Camino to have really the best and the brightest in electrophysiology. And it's one area, certainly in my career, where I've seen an amazing evolution and transformation and progress. Along that line, Chad, could you comment on the risk of stroke in patients who have atrial fibrillation and what are the possible options as to how we might manage that these days and how that's changed in the last few years?
Sure. Atrial fibrillation is like a degenerative disease of the heart. It's like arthritis. So, in your joints, as you get older, atrial fibrillation becomes more and more common. It's 10% of people over 70, 20% of people over 80. And there are two problems with atrial fibrillation. One is that some people feel bad from it because their rhythm is irregular and fast, and they need medications to control the rhythm or the rate or an ablation. But the other big problem is stroke. Your upper chamber, the atria, instead of contracting and pushing the blood out, it actually is fibrillating and shaking, and the blood just sits there and pools. And whenever blood pools, it can form a clot, and the clot can break off and go to your brain and cause a stroke. And it's the number one cause of stroke in people over 65. And the strokes that people have from atrial fibrillation are usually large strokes because the clot in your left atrium is large and goes to the main branch in your brain, and people have sort of devastating strokes from atrial fibrillation. So we really concentrate on stroke prevention. And the mainstay of treatment for a long, long time was warfarin, or the trade name Coumadin, which is a great medicine and has saved a lot of people in terms of stroke, but is difficult. You have to take blood tests and make sure your blood's not too thick or too thin. It interacts with a bunch of food. It interacts with a whole bunch of other medications. And now these newer medicines called direct oral anticoagulants have been really revolutionary. And they're much easier to take. They don't need blood tests. They have much less drug-drug interactions. They have no food interactions. And in large trials, comparing them to warfarin, they're actually more effective at stroke prevention and safer in terms of bleeding risk. So that's really the standard of care right now for stroke prevention is direct oral anticoagulant. And I mentioned in my talk procedural treatment to prevent stroke, the Watchman device, which is a one-time procedure which has equal efficacy at preventing stroke without having to take long-term anticoagulation. And that's been studied in people who are high risk for bleeding on oral anticoagulation, but we're about to do a trial in all comers to see if it's equal to regular direct oral anticoagulants in all comer patients.
That's great. That's a really solid answer there. Thanks, Chad. So, Neil, there are a couple of questions here about how does one's ethnicity or ethnic background affect their cardiovascular prognosis. I'm curious, how do you play into that when you see a variety of different patients coming in?
In this area, there's clearly no doubt that ethnic background can make a big difference in risk for cardiovascular disease. In this area, the highest risk group, ethnic group, is clearly South Asians. Nationwide, African Americans have a higher incidence than white Americans and Asian Americans. But in this particular area, the Bay Area, nobody comes close to South Asians so far as risk for cardiovascular disease. And that actually was the major impetus for El Camino starting the South Asian Heart Center about 10, 15 years ago.
Yeah, no, that's great. That's important. And that's a really very important, very valuable organization here at the hospital. And Kate, how about for you, for women and ethnicity? Is there any extra piece of information when you're seeing women of different ethnic backgrounds, how that might fit into either your recommendations or your evaluation?
Only in really assessing what are the conditions that they're facing, but not in their family history, but not specifically their ethnicity in terms of the course of care that we would recommend in terms of lifestyle treatment. But I might send that over to Jane to if she has some comment about ethnicity in women and cardiovascular risk.
Well, not so much as ethnicity and I'll take that back. So one thing that is national, but again, like Dr. Scott said, that we don't see a lot. We don't have a big African American population here, but one thing is nationally, if you look at African American mothers, they do way worse than everybody else, and that is, I mean, everybody, all mothers do worse than everybody else in the developed world. And that's because I think we don't have the infrastructure. We don't have national health care. We don't have, great maternity benefits, et cetera. So, but African Americans suffer more. The one thing that is very interesting as I'm learning more about, ethnicity, because I also participated in the Chinese Health Initiative, diabetes in the Chinese population has is a pandemic. When you go to like China, who have over a billion people, it is a huge problem because one, they're also becoming a developed nation, so the incidence goes up. But the interesting thing about the Chinese population compared to everybody else is that we get diabetic at a low, quote, normal BMI. So, it's a curse, right? You got to be super skinny to avoid getting diabetes. So you do see that, and it's the same in both men and women. And that goes, again, like the, diseases particular to women, polycystic ovary disease. And these women, they are actually all Asians, Southeast Asians and Chinese as well. Not too many Chinese, but especially sort of like the Southern South Asian population. They also develop these PCOS, polycystic ovarian syndrome, at a lower BMI, and they don't look hirsute. So you have to, there are ethnic variations in all the syndromes that we do see, and we're more cognizant of that now because we're looking at it.
Wow. Well, so I think the take-home message here is the body is an incredible machine, and there are a lot of moving parts, but there are a lot of things that we can do to actively engage and improve it. And I think we could go on and on. I have an avalanche of questions here. It's a little overwhelming. So people who are frustrated that their questions weren't answered, you can connect El Camino Health through the website there, and we're happy to help out and follow on. But I want to thank all of you guys. That was a really great session. And as I say, we could probably keep going and going and going, but I am getting the hook here. And that's the end of our time. So thank you all very, very much. And I just want to thank all of you on behalf of my colleagues and everyone here at El Camino Health for your attention today. And the quiz will come. I'll send it all to you in a little bit. No, just kidding. But I hope you did learn something. I hope you gained a better appreciation of really the deep commitment that we all have here at El Camino Health to provide really the highest quality personalized care possible. So it's a pan-community effort. I think that's, suffice it to say, that's pretty obvious. And at the end of the day, what we want most of all is that all of you enjoy good health and as much wellness as possible. And I hope that you can appreciate, though, that this is not a passive process, and that you've gained hopefully some tools and insight today to not only better involve yourselves in this process, but understand that we are here if you want or need to have help with it. So you're going to be getting an email to follow up today's program. Can you please provide us some feedback via that link, or connect with your screen on the El Camino Health, and we would like to gain as much possible information so that we can continue to serve you better and better. We've obviously been here a long time at El Camino Health, and I think we do a pretty darn good job. I mean, I feel honored and privileged to be able to work here at this institution, but we all know that we can always continue to do a better and better job. So finally, I want to express my thanks and appreciation to all of the hardworking HVI staff and the behind-the-scenes staff who worked really endless hours here in the last few days and for quite a while to put this forum together. So there's really an incredible amount of behind-the-scenes work, and it wouldn't have happened without them. I also want to thank all of my colleagues for the content that they provided, both in their presentations and then what I thought was really an interesting discussion period. And most of all, I want to thank you, the El Camino community, for sharing your time with us, for watching this presentation, asking some great questions, and honestly being who you are. We wouldn't be here were it not for you. So in closing, I want to encourage you all to take action, seriously, take action in addressing your heart, and for that matter, your overall health and wellness. So thank you all. Please go out and have a good weekend. Stay active. That's the message. Keep moving, eat less, move more. Thank you very much. Take care.